All right. Hi, tribe. Good evening, afternoon, wherever you're at in the country. We have Pam and Becky here with us this evening talking to us about their reassignment into a COVID unit. Becky was a NICU nurse at the time. Oh my goodness. Actually voluntarily went into the COVID units. And Pam was a PICU nurse and also didn't voluntarily, but went into the COVID units. So I'm super excited to learn from you ladies and hear your perspective and the things that challenged you and the things that you were supported by, etc. So Becky, why don't you start? Just introduce yourself real briefly.
So my name is Becky Williams. I live in Albuquerque, New Mexico. I actually went to school and started my career in California, but we moved out here about it's been a little bit longer than that. So we came out here. I wanted to work at a level 1 trauma.
Okay.
And my son was in the NICU. I knew I wanted to do NICU, but I wanted to have more than that kind of specialized experience. So I couldn't get that in California because of they don't want to train you there. I think it's a little bit better now, but so I had a phone interview, got hired into the Neuro ICU at UNM, worked there for about 2.5 years, had a lot of burnout, and I didn't really like the person I was becoming. So I decided to go back to the NICU, and that's where I've been for the last 4.5 years. It was a little bit slower than I had planned on, and so I started flight nursing. And so I did all ages, and I was floating to COVID at the same time. So I like to do all the things. So that's what I was doing. And when COVID hit, I knew it was going to be bad. I thought it was actually going to be worse than it was. And it's not great, but it's not the calamity that I thought was going to happen.
Yeah.
So I sent an email to our CNO and said, look, I've been doing flight for the last couple of years. I can run a vent and run drips. If you need me, I'm available. And so they pulled me at the end of April.
Awesome. And Pam, your entire hospital transitioned to COVID.
Yeah,
right?
we did.
Yeah.
I'm up in Seattle, Washington, and we had a statewide plan since this hit us early and it hit us hard, and we didn't know what we were in for. We decided as a state, they would close down all the pediatric units from the multi-generational hospitals and use our transport teams to transport our kids and our infants, not our nursery, but our kids and our little kids, over to children's hospitals. And then we would focus on what we can do to help with COVID, which was mostly adult critical care and adults. So that's what we did. In March, we closed our pediatric program. We got word from the governor's office that that was the plan early in the morning at the start of business that day. And by the end of the day, we were closed. And all of our nurses were shutting down the unit and converting it. I had to take out the pediatric specialty stuff that doesn't work with adults and find a closet to put it in.
Yeah.
And then put all the right cords and monitors and things for adults in and just watch it hit the fan. We were given some basic training. Some of us had some adult experience in the background, like I do. And some of us did not. So Swedish used us for donners and doffers. So we'd watch people go in and out of isolation safely and help them do that. And then others were RN extenders. So unlike, it sounds like you were like taking a full load, right? By yourself. Yeah.
Yeah, but we have extenders.
Oh, okay. Okay. So I got to function as an extender, and to tell you the truth, it was awesome, and I still do it sometimes.
Good for you.
You use all your nursing stuff, and you get to be the one that rolls and tucks and cleans and feeds and communicates and uses the iPads to talk to the family, and you get to do all that stuff, but you have a nurse working with you that's in charge of the plan of care and the communication with the team that you don't know, and with the it's so rewarding.
Yeah, for sure. So I'm just going to tell you guys a secret. Pam's been a nurse since 83, y'all. 83. How long have you been a nurse? You? Oh my gosh. That's amazing. All right.
Bye, Chelsea.
That's so cool. Okay.
Hey, young one.
So, that's so cool. All right. So when did you realize that you wanted to do your current line of work? So Becky, NICU, Pam, PICU, how long have you been in those roles?
Do you want me to go first? So I've been in NICU for over 4 years now.
Okay.
And I still love it. I was in the neuroscience ICU. You don't see people get better. They get trached and pegged and sent to a long-term care facility. And that was a really hard thing for me. So I love seeing the babies get better. But going back to the adult world, I'm now attached to the trauma ICU, trauma surgical ICU. And I kind of miss the adult world. It's like riding a bike again. So I have some really awesome stories about we were surge nurses. This probably goes a little bit more. Why don't we let Pam talk about PICU and then we can talk more about how our hospital transitioned, because we all transitioned at the end of April into making more beds and stuff like that. So you go ahead, Pam.
Chicken. Oh God, Chelsea, your question was how long I've been in PICU, etc. Okay, I did floor nursing, different first adults, then kids floor nursing for the first 4 years of my career in the Midwest, and then I fell in love and moved out to be with him for the rest of my life over in Seattle. And I did bone marrow transplant for the Fred Hutch, got my CCRN doing critical care in that world. It was both adults and kids, because our critical care for that group was very, very small. If you got that sick at that time and you were getting a bone marrow transplant, usually didn't survive that. Plus the Hutch was doing such experimental stuff. So all those chops I used in COVID, like research, the isolation, it just brought back memories of that time in my career. Then in 1999 to 2000, we transitioned, the transplant program left, and we transitioned to open up a real PICU at Swedish, and I've been with them ever since for the last 20 years.
Wow. So Becky, this next question actually leads in nicely to what we were going to talk about in terms of transition. So you both transitioned to a COVID ICU. How was that transition? What kind of training did you get, and what did that look like for you?
So I got 2 days back in the trauma surgical, TSI is what we call it. Yeah. And that's when they decide, okay, can you be a primary or are you going to need to be an extender?
Okay.
And so they were like, yeah, you're fine. So I went back to NICU, and then I think 2 shifts later, they were like, I think they sent a bunch, I don't remember the exact number, but a lot of people went on quarantine. And that's when they panicked and brought all of the surge nurses in. There was, I think they tried to bring in about 50. It ended up being about 25 of us that came from PICU, from outside, anyone that had worked in the ICUs, they were trying to bring in. And so we have 3 ICUs that have 72 beds. We have the Neuro ICU, NSI, we have NICU, the medical ICU, and we have TSI. And then they opened, and this is a separate building from our main hospital. They opened up the pediatric PICU and OR, which is in the same building as the ICUs. And so there's 13 beds in the PICU, and then we took over the ORs. So there's 6 ORs, and they split them in half. So that gave us another 25 beds, and we took over another kids unit, and that gave us another 12 beds. So we jumped from 72 beds to 109. Wow. And so trying to staff that, we've gotten our PPE under control. I think that stayed pretty standard the last 6 weeks. But we have gone from we'll have anywhere between about 90 to maxing out all of our beds. Wow. So, and so I know it's getting better in Seattle, but they're hiring, I think, 60 travelers to try and ease, because people, I mean, it's not, it went from MICU being the COVID unit to now MICU and TSI are the COVID units. And then they took over a pod in NSI for the rollouts. And so we're admitting these traumas, and like just
Where?
god awful messes into the PICU and the ORs, and we just there's no room in the supply. You're spending half of your shift trying to find supplies, and they're doing the best they can to try and splice. But exactly what Pam was saying, to try and change these units over from a PICU and OR or a kids unit into an adult unit that we're big central lines and art lines, and we have the MICU cart, and we have the airway cart.
And then you forget that one thing that you really need, because you're like, we always have it, but you're in a new foreign land, and oops, you don't have it.
Right. So, and sometimes it's just, the techs go get a big cart and we send them down to CDU or one of the ICUs, because the PICU's on the 5th floor and the ICUs are on the 2nd floor.
Yeah.
Just,
Yeah. And it doesn't help that MSC calls an item one thing and nurses call it, right? Right? Oh,
absolutely.
You send one of those RN extenders down with that tap to get what you need, because otherwise you would never come back with what you need.
Well, the good thing is we are staffing our these units with all the adult techs.
Oh, nice.
So that does help, but it's put an incredible amount of pressure. But we usually have at least 2 extender assignments each floor. And that it's hard. All the extenders are different, and they're they offered extended assignments to our NICU nurses that don't have any adult training.
Yeah.
And I'm like, go for it. Do that. You're green. It's good for you. Just stick with it. But it's also, it's harder on the nurse that you have 4 patients and you're just trying to figure stuff out. Trying to
have a girlfriend. I actually have a couple of girlfriends who were former pediatric ICU nurses that are now doing clinic and different things. Their positions were closed, like they weren't needed, and so they were forced into adult ICUs, and they've had quite the experience taking adults for the first time ever. And it's a crash course on the toolbox you guys have, because your adult toolbox is way bigger than a pediatric toolbox.
Yeah, and what do you mean you keep the sedation med in the PICUs? We have to get all our specialty made. Yeah, you're laughing, but all specialty made, they just go to the PICUs and pull out that Versed and pull out that fentanyl. I'm like, what the heck?
Right.
That's what one of my girlfriends said. She said, actually, you would be surprised about how easy it is, because everything's standardized. Nothing's weight-based. Everything, just push it.
But I'm so glad I'm just an extender, because can you imagine me dosing something milligrams per kilo?
I know. Well, and that's the funny thing, is because I actually went back and they changed all the pressors to mics per kg. They changed, and I was like,
some of them,
Oh,
wow. That's awesome. I mean, not vasopressin, but well, I guess that is, but that's pretty standardized. But they like my Levofed, I'm like, and then there's double strength and quad strength, and I'm like, that is my favorite drug ever, but you're okay. I got to figure this out. So I had to translate my brain to make things work.
We've had a little different situation with staffing. We're so huge. We're over 650 beds, and the largest hospital in Seattle. I haven't looked at how many beds UW has lately, but we had a lot of traveler base. And so what Swedish did is reached out to the organizations, fast staff, et cetera, that they already had relationships with. And not only did they bring in staff, but they paid them the bonuses that you hear people talking about for the travelers.
Yeah.
Right. But not for the staff. Right?
No. Yeah. No. I shouldn't say that. If you worked extra hours, our contract provides for the wage support. But if you're working your FTE or, within guidelines, no. But what I was saying, travelers, et cetera. So we had that staff. So as an RN extender, I was working with I had like 2 nurses I was working with, sometimes just 1. And they had a regular assignment. They weren't taking care of 4 patients at a time. They were taking care of 2, sometimes 3 if they were a step-down patient along with criticals and stuff. And if they were really, really bad, as these COVID patients can get, they were still 1-to-1 with us helping. So the dialysis and the vent and the flipping and the proning and all that was involved. And we did all the drug studies. Love remdesivir, love, love, love. High dose vitamin C, proning, all that.
Yeah, I wish we were using extenders for that, because 4 patients is, I mean, I won't.
I'm so sorry
if I don't.
No. And then the families are frustrated because if you have 4 patients, how can you keep all those families? And, they can't come. So you're their link. Mm-hmm. And so I know a lot of times the nurses I was working with were talking to families on the phone. That's why I got to do a lot of patient care and, stuff that I get off on.
Yeah.
Because they were busy. I can't imagine doing that with 4.
Yeah. No, it would be great to have, because there's sometimes where, like, patients, and this is on the non-COVID ICUs, like on the PICU PACU. Like, I can't turn my patients for hours because they're too big, and 2 of us couldn't do it. So we could not get that 3rd person to turn. And, you can't. And it just kills you. And, there's stories out of Gallup about how nurses, they were so short-staffed there, and how patients would be on their call lights all night. And it was all they could do is to pass meds and keep people alive there, because they were so short-staffed. They would have 9 patients. It was ridiculous.
Oh, that's crazy. Yeah. I'm old enough. When I started as a med surg nurse, I had 13 patients on an evening shift. But, acuity was different back then.
Right.
Team nursing was the way, and I had an LPN or an NAC with me, so that each patient had that person and me, and so I could take care of 13 patients that on a med surg floor when you were there for 7 days for having your gallbladder out because they use T-tubes with little billy bags on the outside of your body. I mean, it was different. I can't imagine primary care nursing with today's standards and today's detail and research. And
Well, and in New Jersey, nurses are actually, they're getting a stipend for, I don't know if it's crisis pay or something of that type. But anyway, so a traveler that we did a Q&A with a few weeks ago, she went out there, and the staff nurses were making just as much as her as a traveler. Seattle pays pretty well.
We do. We're fine.
Yeah.
Cost of living is high, but we're getting wages that we could be a primary caregiver for our family, and definitely.
And I work nights.
We worked hard for that contract.
The differential is a lot different, but I figured from the very beginning we would lose a lot of day nurses because we talked about hazard pay. And it wasn't in the budget. And so they did offer overtime incentive contracts. They do have double time COVID shifts that you can sign up for. I haven't offered double time at my hospital in adult ICU, outside of like L&D and PACU and Path Lab. They haven't offered double time since I was hired there. So
we're on. I'm sorry. Did you get a lot of community support too? I mean, financial's good, but it felt really good. Some of the restaurants were bringing in food for us.
Absolutely.
It was so cool.
Yeah.
And organizations, one in particular that I volunteer for, they gave me flowers and a card that I could order food and some bath salts. And
nice.
It's like, oh, you guys.
Yes.
That was really good. And the city of Seattle has free parking on the streets. And if you know Seattle, that's a big deal because it's really expensive. And the hospital has free parking because they're trying to keep us off the bus and off the, I took a boat to work, so they don't pay for that. But if I have free parking, it makes it affordable to get on the ferry, drive on, drive off, just to keep us safe and from getting sick. By having to take community.
They closed the dorms at University of New Mexico, so they offered those to the nurses that either had to drive too far or needed to stay away from their families. And so we still have nurses that are using those dorms and allowing us to take showers there. And we actually, for the COVID units, changed into hospital-provided scrubs.
Yeah, us too.
We don't wear our scrubs. And so, they're doing the best they can, and but they've had a significant amount of nurses quit, which is why they're having to bring in 60 travelers. And you know what? If you could just have paid an extra $10 an hour, especially for nurses, you would have had these experienced nurses and not having to bring in travelers. So
I think that's
so hard. This is just, I'm the little peon. So it's just my opinion on this subject. But I just feel like, you know, and they're trying to get the surge nurses out back to their units. And I'm like, there's only 20 people. There's only 20 babies in NICU. They don't need me. I figured once they pulled me with all the surges that were coming with opening things up and then school and then respiratory season, it would easily be until next spring that I would be doing this.
Wow.
So, just, we don't have that many, you know, this is Albuquerque. I love working where I do. I love the city, but it's not the easiest place to recruit. So
Let's talk about your PPE standards. Like, what's protocol? Some facilities are using PAPRs, some are using negative pressure. Some facilities have transitioned units upon units to negative pressure rooms. What does it look like for you?
For us, we do hat. So I'm going into a room. Hospital policy says only if it's aerosolized do I need to wear N95 or a PAPR.
Okay.
No way. All nurses taking care of positive patients, and we don't have visitors, right? So there's a positive sign on the door, right? And there's a DNI sign or not on the door. It'll say full code, or so that you know what you're walking into. And we're not doing HIPAA because there aren't any visitors around. So anyway, we do hat. If they're positive, we do hat. N95 covered by paper. We do gown. We have shoe coverings sometimes, but we don't have them often enough that it's a routine. And a lot of nurses aren't wearing shoe covers. They will wipe their shoes down in a square right outside the room and then go, just assuming that always the floor is contaminated, your shoes are contaminated. We wear hospital scrubs, one gown, PAPR if you don't fit test. We have 2 sizes of N95s, not 3. So make sure that you are fit tested with one of those 2s or you wear PAPR. We're having trouble right now with PAPRs. They're starting to wear out. The batteries are being dropped. They're broken. They're being held together. Our duct tape is the foam tape. Am I talking? Right? Foam tape. That's our duct tape. And so they're being held together by that for those. And the hospital's really working hard. I reached all the way up to the CNO. I'm on committees at the hospital. She knows me by name. I said, okay, what's the status? She goes, we're still working on it. We're still working on it. Getting more. We have enough, but we don't have enough if we surge or if more keep breaking. The other day I was in PEDS procedures and I had to go up to the adult ICU and adopt one for the day. So our physician, one of our 2 physicians working down there with me, had the PPE she needed. But so that, and negative pressure is a given. Whether
all COVID patients are in negative pressure.
All the COVID patients are in negative pressure, has to be. If they test, however, if they test out and they test negative, they're out. They're to a different floor, a different space. We have 3 ICU units for adults. We were using 2 for COVID and 1 for regular. Now we're using 1 for COVID, 2 for regular, and IMCU. And IMCU had moved to our PEDS unit, right? So now we're open. We have 1 IMCU, and the COVID ICU is being shared with regular patients. So that's how much it's calmed down. And we have 1 floor negative pressure, regular floor for COVID, and another one that does both COVID and regular. So we're doing a lot better. But all negative pressure, and some of those units, the filters started failing because they were so full of. So we're like, why aren't they holding? Why are they alarming? And he goes, oh, look at this. And then he showed me the filter, and it was like dark spot, dark spot, dark spot. It was just that the filters need to be changed. Yeah. Because they all started in use at the same time. They're going to all start filling up at the same time. Yeah. So he went and started changing out all the filters and putting more duct tape around where the ducts meet the box that holds the negative filter. Because these are makeshift negative flow rooms. Yes. Right?
Yeah, makeshift negative flow. Yeah, units. Yeah.
So you guys are doing the exact same stuff, Becky? Anything different there?
It sounds about the same. They've converted the 2 ICUs into negative pressure, and the rooms are as well. And then there is one step.
Unit is.
Yeah, one step down floor that they converted. It was the OB special care is now the COVID step down floor. And then in the main hospital, because it's quite a distance away, I can't even think about how far it is, but it's a significant distance between, it's 2 separate buildings. So we have
a sky bridge.
Exactly. Thank you, Chelsea. So we have 2 COVID units over there as well.
Okay.
We're at half capacity. We only have 450 patients pretty much.
Wow.
So right now, so they're starting elective procedures starting yesterday. No, the 1st, I think. So it'll be interesting to see how things go. And then with summer, people are getting together. We have a lot of trauma. We don't have helmet laws in New Mexico. So it's a special place to work. And as much as I love it, we get a lot of and we've seen Hanta patients too. We had a Hanta patient last week on ECMO. So it doesn't, and then, now it's just never ending. So we're about 4 to 6 weeks behind you guys in Seattle, I think.
Okay.
And we're still getting patients from Navajo Nation up in Gallup and Farmington.
Yeah.
There seems to be a lot of more education, and shutting Gallup down, I think, helped, but it's not going away. It's still out there. So we don't, we thought it was getting better about 2.5 weeks ago, and we were starting to empty out. And then last week, it was totally full with we were boarding patients in the ED because we had no beds. So, and then this week was a little bit better. So I have no idea what I'm going into tomorrow.
So how is staffing working? So you've got dedicated you've got dedicated COVID units. Are those staff dedicated to that unit for a period of time? Because to me, it doesn't really make a whole lot of sense if you have COVID nurses and then all of a sudden you're a NICU nurse tomorrow. How is that going to work? Are you going to have to quarantine for a period of time? How is that transition going to work?
Since I'm the only one doing it, we haven't figured that out yet.
Okay.
So what we're doing in Swedish, and in a given day, I can float to 2 different areas or 3 different areas. So far, it's worked out that I start in cleaner areas, like I'll be in the nursery for 4 in the NICU, and then they'll need me over in OB to help a COVID mom deliver. And then they said, okay, now you're there. I'm going to send you to the adult ICU COVID.
Yeah.
I've not done the opposite way, and in fact, I'm working with shared leadership in our nursing leadership. I got permission from our manager of the adult ICU that we can use their showers, because the only difference is because we can any day you could work in COVID or you could work in the nursery. They're not telling you can't go from there to there because you're wearing full protective gear, and some people are even going grocery shopping. So, so we're not doing it that way, but CME guidelines really recommend, even doctors don't round from COVID to regular to COVID in a given day. That's their written guideline. So I'm trying to get that, and they don't have guidelines for nursing care. So I'm like, what our standard is personally as professionals is we change into hospital scrubs, we work in COVID, we change out of those scrubs at the hospital. We come home, we go to the shower.
Yeah.
So if that's what we do to protect ourselves, we should do at least that to protect our patients. So we got permission to shower at work if we get floated from one area to another. And of course, you have to shower, change your scrubs, and then go. Yeah. And that takes a little time. So I needed a blessing to get that paid for and done.
Yeah, I mean, because I went from working 3 shifts in COVID, and then I did an overtime shift on Sunday, and I was in the adult ICU in the operating room. So it's just, and our PPE is about the same. I think I got sidetracked on that, but we've changed into our scrubs. And then when we're on the floor, we have to have a mask and goggles. And then when you're going into a room, you have to have I always do my N95, my goggles, and then my hat, and then my mask over the
and a shield. You wear goggles. Yeah, we wear shields. Yeah.
Or, that either way.
Eye cover.
Yes, exactly. So, and a lot of times I'll have all my headgear on. So in case there's an emergency, we have to go into a room quickly. All I have to do is put on a gown and gloves, and then I'm good to go. And I just doff afterwards, and then, get everything. And we're not using, they found shoe covers didn't really show, but I like the idea of keeping the shoes outside of the room. I think we institute that because we don't do that. Mm-hmm. We're just really dirty. Yeah, but those, I'm like, just go home.
Yeah.
Get a glass of wine, get in the shower.
Yeah. Wine's good. Wine's good.
All right, so we had some questions come in about proning COVID patients. So we know now that proning is good, but in your practice previously, did you prone, and have you seen proning relatively effective or ineffective? What's your experience?
So, I left over 4 years ago, and I was in the Neuro ICU. So we only saw ARDS as related to other diseases. So we didn't prone a whole lot, but when we did, it's very effective. And it's part of the ARDS network. That's what you do, right? So we do prone our patients, and you'll see, to try and keep patients from getting intubated, we'll try and get them to prone themselves. And some patients will prone themselves. It's just hard if they're heavy, on the obese side. They do not tolerate being prone in which way. So and I've only been there about 4.5 weeks. So with my limited experience with the proning, some patients, it works. Sometimes they're okay when they're prone, but it's when you flip them over, they're like, oh my God,
this is flip them back.
Better than that, so actually it transitions them. So you'd think they would oxygenate better being prone, but when they turn over, they're so happy, even if they're incredibly sedated and paralyzed, they're so happy to be on their back that they actually do better, and we need less oxygen there's a pediatric doctor that said, proning is tummy time. And so now I'm like, okay, tummy time's over. Let's go.
Those adult nurses, they love seeing the peds group come in. They're like, oh, you need this. Because they know we're so used to. You ever chase a toddler around a bed? They prone themselves, man. Right. But in the PICU, we did most of our proning on oscillator patients and such, and the other ones we didn't worry as much about, even though for a kid it's airway, and viruses. I think when we get back to full blast with our PICU, we're going to be doing a lot more. No matter what the doctors think, we're going to be doing a lot more proning. Yeah, we are really good at it.
With those high frequency, jets or oscillators, they only have two positions. They have to be either flat on their back or flat on their belly. So you have to be proning. I mean, that's,
Yeah. And
everybody needs a little tummy time, apparently.
Everybody does. Towards the end of my time in pediatric ICU, we were doing a lot of proning, and it was shown to be super effective in our numbers, both in keeping people from being intubated and shortening their intubation time if they were intubated. Yeah. And so I love that you guys are going to hopefully make that shift when this is all over for you guys, Pam, because it is super, super effective. And I love that this has been the movement, and it's an art, right? Like it's art, all the lines and everything. Like it just has to be.
We do it in NICU all the time because when they're after they're born, they're on CPAP, and the first thing you want to do is put them on their belly and get, that's where they're gonna, do better. The doctor.
Yeah, we have special NICU pillows for proning. Yeah, they're awesome. Yeah, they're really cool.
Super cool. All right, so let's share your most effective treatment, and if you've seen the efficacy of convalescent plasma. So why don't you share what you've experienced there?
We are using the plasma, and why wouldn't it work, right? But the issue is, how long does it give you protection, and how do you measure how much protection any one individual? So time will tell. Yeah. We're using high dose vitamin C on everyone. We're using remdesivir, but I'm a nurse extender, so I think my partner here is going to have to be more of an input person on that. High flow nasal cannula we used on kids way before they did on the adults, and the adults are up to 60 liters up their nose and 100% O's, but if you can keep them off the ventilator, yes, do it.
We're a research hospital. They're still researching and trying to get that plasma from people who've recovered from COVID. They're not doing a lot of antibody testing on people that haven't. They're not doing it on the nurses for sure. And I think they're having a hard time accessing that kind of stuff, and they're still doing research on it. So I haven't seen the plasma being used.
Okay. We have companies here that, I mean, there are several nurses enrolled in the study, and we've got call out for volunteers to give plasma, and yeah, it's pretty. We have a blood bank that's really proactive. The University of Washington is pretty up and on that, and the Fred Hutchinson Cancer Research Center is also doing studies that people can enroll in here in Seattle. So
I'm hoping that will start being part of the treatment, because we're not having a lot of success getting people off ventilators.
Yeah.
That's kind of the next question was, how many critical ill cases have you seen that don't have any pre-existing conditions? And it actually might be better for you to answer the next question first, since you were talking about extubation and intubation. Have you seen patients successfully extubate and transfer out of your ICU? How long were they there prior to transfer?
Yeah. Two of note that were really kind of cool to watch were nurses. One was a outpatient care coordinator from a clinic who had gotten sick. I don't think she had any, but like me, she wasn't a spring chicken. I guess you could call that a pre-existing condition. Sure. But she was trim and active, and I think probably overworked and tired, and she was, I don't know, 60-ish. And so if you can call that a pre-existing condition. Sure. But she got really sick, and then she got better. And then another who was like in her 30s, also a nurse, but in a retirement home. Mm. And she got really sick. I mean, we were proning her and so many medications and everything. And I heard she walked out last week. So
that's awesome.
But they stay for a month, right? With critical care, they stay a really long time. This stuff it smells, it's thick, it's gross. But yeah, there are some without pre-existing conditions, especially some of the young ones. And I don't know if it's just that they're burning the candle at three ends and then had exposure for an extended period of time, or it's just the luck of the draw. But we see all age groups. Certainly more elderly, and certainly more with pre-existing conditions, but it's not a requirement.
Well, and being in New Mexico and Albuquerque, a lot of people have pre-existing conditions here. So, and even if you had somebody that was in their 30s that worked out all the time, you don't know how much stress they're under. You don't know. I mean, so exactly like you're saying, pre-existing conditions. I think people are trying to hang their hat on that.
Yeah.
And it's not a good idea. You do not want, this is the conversation I have with everybody. You do not want this disease. I mean, even if people are asymptomatic, do not expose yourself to this disease. Yeah. It's not like chicken pox parties. You do not ever want to be in one of my ICUs. Mm-hmm. I have some amazing stories and some stories, but being on the ventilator, the ones that have been able to be successfully extubated, I think you can count on one hand. So the best thing we can do is do the high flow and keep them. One of my favorite stories was it was another nurse that was terrified she was going to die. She was convinced she was going to die. Young, did have pre-existing conditions, but we used the incentive spirometer, and she started coughing and just totally decompensated. So we maxed her out on the high flow, put her on rebreather, and the docs are all outside, and she's like, what are they looking at? What are they doing? And I'm like, go outside just for a second. Let me talk to them. I'll be back. I promise. This is good. It's going to be okay. And so they're like, we have to intubate her. And I was like, no, you don't have to intubate her. And I'm like, she will tell you she is totally with it. And she will tell you that she does not want to be intubated. And if we can keep her not intubated, it's going to keep her alive and able to get out of here a whole lot sooner.
And thinking she's going to be alive. You
Exactly.
need that.
Right. She needs that. Yeah. So they're like, but we just don't have anywhere to go. She's maxed out. And I was like, okay. So this is where my flight nursing came. And they don't know me from Adam, right? They're like, who is this nurse? And I'm like, so do you guys do awake intubations? Like, can we use ketamine? Then you don't need to reoxygenate, And they're like, yeah, we do that sometimes. But I'm like, look, man, we could do BiPAP. I'll do whatever you want, but this is not. We should not be intubating this woman unless she is altered. We need to do everything else we can. And so they're like, So it turns out 2 weeks later, I kind of was monitoring her from the other units. She was able to. The last time I saw her, she was on 4 liters in our step down.
Yeah.
So, it's maxing out at, Becky, on high flow. Are you doing
60 liters, 100%, and then she had the non-rebreather on. So, and we actually find that the patients do better not using the IS because it makes them, the incentive spirometer, it makes them cough, which they just decompensate like crazy. So we use this little thing called the flutter where they blow into it. And I harp on the ones that are not intubated. Like, I'm like, this will keep you from not having a tube down your throat. I get my mama voice on. I'm like, whatever you need, I can give it to you.
I like the Arabica for kids the young kids, because they can't quite figure out how to do the IS.
Right.
So I was very comfortable with it, but our adult team wasn't so familiar, and I introduced them.
Yeah, that flutter, because it keeps
nice.
it helps enough that but that IS I have found it just makes them cough, and then they just decompensate.
I think that vibration on the inside is like an oscillator on the outside. It just keeps that thick stuff moving, and I
didn't think of it that way, but that's a good way to.
Yeah.
They have no idea what an oscillator is, so.
Yeah,
that would take a long conversation.
I met, as part of this, my most memorable COVID patient was this little lady who is used to healthcare stuff. She was born a preemie, like 25 weeker, and she was 70 some years old. And I'm like, what? Miracle walking. She goes, oh yeah. She was blind because she had ROP. Like retinopathy and prematurity, and she would use her cell phone. It'd just be a blank cell phone, look like this to me, nothing. Look like that. Well, it looked like a blank screen to me, and she'd rub it, and it would talk. She was so amazing. And same thing. She's like, we put her on BiPAP. And I said, this is what she needs, just to help her, just to take a breath, because she was getting too tired to take a breath. But yet to put her on a ventator, I said, no. You're going to kill her. She had like 3 weeks that way and survived through it.
You can just do that, and, you let them sat 85, 86, and you just have to, as long as they're with it and they don't have, it used to be, GCS less than 8, you intubate. Yeah. Well, GCS less than 14, then you can intubate these patients. It's just like, you got to let them try and fly. And unless they're crashing, you don't, and that's my personal opinion.
Yeah. And we're still getting, even if they're intubated, we're still getting them up in the chair and such, but what they're missing is our adult team is used to walking them down the hallway on a vent, because you can use agents that don't knock you out. You can rationalize with an adult and say, hey, this will get you there. But with these patients, they're totally stuck in their room.
I've
So
had a lot of luck with that. A lot of our patients, not a lot, let's just say some have issues with alcohol use in New Mexico. And so the amount of sedation and people on paralytics for a week or two, I mean, it's a lot. So we don't do a lot of that, like PT and, walking them around when they're vented. So because you could think that you're rationalizing with them, and the minute you turn your back, and they'll play. And then, if they have a difficult airway or if they're swollen at all.
All those parameters, and they don't do it here, but they do it a lot. I think I've walked one ventilated kid. So
well,
the adult team's just better at that.
And we're seeing a lot of patients go up on ECMO. They don't usually do that well, but we use ECMO for everything these days. It was so funny because when I was in the adult ICUs, we would use ECMO for hantavirus, and that was it. And now we're using it for everything, and it really can be effective. But we're seeing people on ECMO for months.
Just how risky that is, blood clot potential, etc.
Well, that's the guy in New York. That's the famous Tony-winning actor lost his leg from a clot from ECMO. His name off the top of my head, but that's, he was healthy. And so,
So what would you say your top 3 challenges you and your coworkers are facing in this pandemic?
I wrote those down because I'm like, I'm not going to remember. I think working between units. We get to work, we don't know where we're going to end up working, and then how do you transition from one to the other and back again? And then family, home, and kids, because King County for sure is still shut down tight, and the others are phasing up, but no one's going to school. A lot of people are still home from work, and trying to balance the needs of elder care and kid care and working, and then oops, somebody got exposed and such like that. And then job security amidst all of this. We need nurses, we need help. They're laying off nurses and laying off doctors.
We need certain nurses. That's
doctors were told they would get paid to a certain point, and then after that they had to be available to be shipped throughout the system. And then us as a team were worried, well, if you get shipped to Montana, Alaska, are you coming back to us when we need somebody of your skill level and your expertise quickly? How is the system going to navigate that? And are they going to see and sense the patient care needs that we see at the bedside? And they're making decisions. It's just a puzzle sometimes. That's a challenge.
Well, if we could predict what was going to happen next, it would be great, right? But you just do the best with what you have.
So what about you, Becky? What's the top 3 challenges you and your team have faced with COVID?
Well, we really struggle with the 4-patient assignments. Like I saw that was a possibility with like New York and New Jersey. They had their tiered system where, you'd have one critical care nurse for 6 patients, but you'd have like 3 or 4 assistive personnel underneath you. Well, I'm sorry, but 1 ICU nurse to 4 ICU patients with an extender that, I have not had any issues with any of my extenders, but, you have to have a very open and very clear relationship with your extender. And so we're the only union in New Mexico. And so there's a class action grievance against having 4-patient assignments, but also the surge nurses that were involuntarily pulled did not agree to come. They don't want to be there. And I understand. It gives, I feel bad for them. I wish they didn't feel that way. For me, it was just like, this is where I'm needed. This is something I can do. But it's hard to have that outlook when you've been, there's definitely a sense of resentment when you're getting pulled.
Sure.
And then, and kind of no rhyme or reason. Some people are being pulled and they're not letting them go, and then some people were pulled and then they were able to go back to their unit, you know. So that's really been a struggle for some people, and I hope they can figure out how to resolve that. I think they're hoping bringing in all these travelers will help. I always worry about, you know, UNM functions a lot with a lot of travelers in the adult ICUs. So I always worry about care. Some travelers are fabulous. Like Chelsea, I'm sure you were a great traveler. So, but,
she was.
Right? You're getting travelers from all over the country, and, you know, the knowledge base is always different. And a level 1 hospital is totally different from, you know, a level 2 somewhere else. And, you know, I know that they were pulling contracts, so I'm hoping that we're getting the cream of the crop here, since a lot of those contracts got pulled. But I know we're not offering $5,000 to $6,000 a week for travelers either. So, you know, so we'll see. And having that many travelers, you know, that don't know the system is really I'm like, please don't send me back. I'm fine. I you know, I know the system. It's okay. You can keep me there.
So asking based on Pam, you mentioned something about exposure to your family members at home. If you were asked if your if your institution is offering you yourself to be tested, asymptomatic, just because you feel the need to be tested, are they offering that?
So all of New Mexico is offering, you can go get tested. They have testing centers. Anyone working can go get a test.
Okay.
I had this conversation with my chiropractor because somebody asked the chiropractor, you know, how often are you getting tested? And so she asked me, and I was like, I never. I'm not symptomatic. I have no symptoms. Why would I waste a test on myself when I don't have any symptoms? So, you know, I think people have a hard time understanding that a test is only a snapshot in time. It doesn't mean you didn't have it. Right. You know, you didn't have enough viral load 10 minutes ago. It doesn't mean you have enough viral load 10 minutes to test positive. So it really, I mean, I understand why they're using it, because it's the only way to open things back up again and have sports and all that kind of stuff. But really, for healthcare workers, there's no reason to do antibody tests or regular tests unless they're symptomatic or they have a vaccine. There's just no, you're just wasting money. You're flushing money down the toilet. So that's my.
maybe someone wants to get tested because they, you know, on the off chance, and then they could get some time off work.
If you've been exposed and you know, you're concerned about your family, absolutely go get tested. But just know that's only a snapshot in time, and you still could be sick.
Negative today, positive tomorrow.
Exactly.
Yeah, I haven't heard that what the state did do is you're not going to be charged for the test. Yes. So no matter if you have insurance or don't have insurance, it's going to be affordable. It's not going to throw anybody off, because some employers are, even though they don't have healthcare coverage for their employees, are saying go get tested because exposure, symptoms, good reasons. Yes. And so they did provide that. But employers saying just go get tested, no.
Right. So it's more just to me. And then that always concerns me, like, go get a test. Well, what is that? Like, is that just to make you feel better? Because will that make you go out without a mask? And really, let's talk about like the actual psychological effects of going to get a test and how, we're nurses. We have a very strong base in reality, right?
Yes. Right. I mean, it's twofold, right? So one, you're giving yourself a false sense of security.
Exactly.
Two, the incubation period is 4 to 14 days. That test is, like you're saying, just a little piece of time. Really, if you're not having any symptoms, and something that the girl who I interviewed a few weeks ago who did a travel assignment in New Jersey, something that her and her husband decided on prior to going was that she would have 2 negative tests prior to returning to him and their children. And so before she left, she got tested, and then she quarantined away from them for 2 weeks and got tested again. Both were negative, and she returned home. But they had a very stringent plan to protect their family.
Right.
And I get it. But she was feeling super safe over there. She felt like the level of PPE and the measures were just phenomenal. She didn't feel as safe going into a home unit. That didn't have all the PPE and everything that was originally.
And they're still changing things up. Like our N95s, we got, I think, 3 shipments from the national stockpile. Right. So we had like 5 different N95s. So so I'm a fit tester, and like you don't get fit tested unless you're going to use that mask on the unit that day, right?
Right.
So I get a lot of shared governance units hours for doing that. But and then there are the PAPers. And then there's certain N95s that they're reusing. They're doing the hydrogen peroxide cleaning.
Yeah, we are too. They were going to use the chemical first, and we're like, then they switched to a company that does. Yeah, it's much nicer.
You know, it's not my favorite thing. I would prefer to have a new one. But if there's one that I get that I'm like, I don't really like this one, I'll like turn it in and then get a new one. And and I usually work 3 to 4 days on, and like I had the last one for 3 nights straight because I was like, I like this one. This one's working for me.
Yeah, I don't know. I feel uncomfortable. In the beginning, we had to use the same mask to give us a little Tupperware, put it in, which I still have. And sometimes I'll wear it 2 shifts because I just feel real comfortable and I wasn't in the rooms all the time.
Yeah.
But, you know, those are meant to be a one-time use. Even the fact that we're using them all day is a breach of the way they were built and what they're for.
And that's absolutely true.
And, you know, I
know.
So we're not doing it.
There'll be some interesting studies out there in the next couple of years coming out. But you know, it's been 4 weeks of being exposed like that for me, and I do have an amazing immune system after having children and being in the hospitals for as long as I have. But I haven't, and we haven't had any. As far as I know, and I'm not in on everything being a surge nurse, but we haven't had a mass amount of people going on quarantine or exposures or being positive that I know of, even with those institutions. Yeah. So
our hospital put all of our peds nurses and all of our PICU nurses into COVID if we were under 60 years old. And we haven't had a mass exodus for illness either, so.
That's good.
Yeah.
So if you had to say that something positive came out of you being, you, Pam, being forced, and Becky, you voluntarily going into this COVID ICU environment, what positive would you say someone that's being forced to go into this situation, what positive can you glean from this?
Well, I really get off on doing the actual patient care. And as an extender, I get to do so much more of that and so much less charting and all of that it's been a real boost. I was like almost to the point where, okay, I'm done being a nurse. I'm going to retire now. That's because I can. I'm that old. But it gave me a refreshing, like, why do I do what I do? Because these patients are so sick and they really need you, and their families are so appreciative. The community was so appreciative. I mean, now they pretty much think any nurses doing COVID are pariah. But, you know, especially in the beginning when there was this feeling of we're all in the same boat together, that was good, and that was a takeaway, and it bridged the gap between adult nurses and PD nurses.
Yes,
that was kind of cool too. You know, and the first time they said, I need an otoscope because this lady doesn't, and there was no otoscope to be found on the whole adult ICU. I'm like, of course, you can find one.
That's so funny. Of course, they don't need an otoscope.
No, they don't look at eyes. No, they're not into. But, you know, our group, of course, knows that area of the body really well. And so, yeah, I think it bridged between, you know, we're such a big hospital, so many different specialties. It got a lot of specialties, the PICU, all together. And I think I like that. I love the value that was put on it by community and the value that was put on it by, welcome back, by the nurses themselves. That was really cool. That was a shot in the arm.
That's good. Becky, what was the most positive thing you experienced?
Well, so even though I was flight nursing, I had quit in December, and I thought, I've done it. I don't need to have that. I don't get the adrenaline rush anymore when you're having to run a recess or a code. I thought I'd never lose that I was gone. I was like, oh, that's kind of sad. I miss that. But, you know, I've gone to TSI, and I never did CVICU. And I'm like, you know what? Maybe I need to go back. Like, maybe this is where, at least for right now, this is definitely where I need to be. They don't need me in NICU. There's plenty of nurses there. But so, you know, now I'm like, well, is this something that I need to pursue? Do I need to go back to the adult ICU for a little while and then postpone my retirement into the NICU? Because that's like, I'm going to be doing NICU for a long, long time, you know? So, but, you know, there is something about being an advocate of taking care of these people, of like knowing what to do. Like when we were proning people, we weren't feeding, or we were doing trickle feeding. Well, now there's studies saying that we should feed, but that just happened in the last week. And so, you know, it's so interesting to see how things are changing and how fast things are going. And I'm like, I'm missing out. Maybe I need, and the people that I work with on this specific unit are really awesome. So, you know, it's like, well, maybe I was like, I don't want to lose my seniority, but maybe I need to make it. I don't know. So, you know, you kind of, it makes you explore new things. And man, like I said, using your brain in new ways is so good for you. Like, you know, doing one thing for the rest of you, that's what you're supposed to do. That's awesome. Do that one thing. But man, if you have any doubts or want to go try something else, do it. It makes your brain work better. I promise, especially after you have a baby.
No. Especially after you go through menopause.
Okay. Not quite there yet, so that's good to know.
I'm telling you, it's coming.
Well, it's headed my way, so you know I'm gonna have to deal with that pretty soon. So maybe you know, gotta go back, and you know, so so many new things to learn, and things change so quickly, and so
that's one thing about nursing. It's always changing. It's always dynamic. But when you get a crisis like this, it goes in hyperdrive.
For sure.
It does.
So if you could give,
then I really hope that people recognize what nurses do. Can you hear me?
Yeah.
Sorry.
Until they're a patient, you can hear you.
Okay. You know, and you see on Grey's Anatomy, the doctors do everything. Well, no, it's the nurses that are bedside. They're the ones that are telling the doctors, no, there's something wrong. You need to deal with this right now. So I'm really hoping nurses, you know, we're getting this hero label, but I want them to recognize that these nurses are making exceptional decisions in real time, and they will make your families.
Especially in critical care, I mean, that's exactly it. You are the eyes and the ears of the diagnostician behind you. And the doctors know that that's their true function. They're diagnosticians. We're the care providers, right? So you've got to have both working really well. You need the diagnosis or your care goes all in the wrong direction. But if you diagnose, but there's no one to care and fix that problem,
and to advocate, like I mean, it could have been a traveler that would have, like for that poor nurse that was in there, you know, it could have been anybody that was just like, okay, well, yeah, we should intubate because the doctor thinks so. Well, you need somebody to advocate for you.
Yeah, for sure.
I might have not been, I'm not always right, but I was pretty sure I was right in that situation. So.
And that's a big piece of advice that we tell new grads: go with your gut. You will, right?
If something smells wrong, or just it's like that little tingling. You have to investigate it. Like you're like, that number doesn't look right, but I'll check into it later. No. You got to stop and think about it right then.
Yeah. So we're going to close with this. If you could give a few pieces of advice for nurses who are about to be deployed into COVID ICU units and they're freaking out because those who didn't get to choose, they're truly stressed and they need your advice. What advice do you have for them?
Don't focus on the fact whether you chose to go or you're being told or asked to go. Focus on the fact you're going and what you can do to make the best out of that situation. Wash your hands, wash your hands, wash your hands. Use your gel. Remember that it's all about the patient. It's not about you. It's not about, so if you go in to try to find the best situation, the best part of healing that you were trained and the reason you took nursing and run with that, that's what the patient's going to sense. That's what the patient's going to get their strength from. And you might just find you love it like I did.
I love about both of you sharing positives before this question, because as you can see, positives will come out of any situation if you just.
Oh, yeah.
Yeah. And I know there's a lot of fear involved and uncertainty and, because you are putting yourself on the line by doing this. I mean, and I think it's about recognizing that, embracing that fear, doing what you can to protect yourself, and speaking up when you're not getting the stuff that you need to protect yourself.
Yep.
But know that you're getting pulled into this because you can do it. Mm-hmm. And you are a unique person for being able to do this. And it doesn't matter if you're a primary nurse, if you're an extender, you're being pulled because you have exceptional skills and you can take care of these people, and nobody should die alone.
No.
I love it. You ladies have any final words of advice or anything you'd like to share in closing?
Oh, I always have a lot to talk about, but you guys can message me in my DM and ask any question. Very, very honest and opinionated for sure. And I did drop one swear word. I'm very proud of myself.
They happen. No worries.
I'm an adult now.
One final word of advice, just do it. Help write the history books on this thing. I mean, if you want to leave this life making a mark, this is one way you can do it.
Absolutely. Thank you, ladies, for your time. Thank you, everybody who tuned in. You guys have a wonderful night and take care. Be safe.
Thanks.
Bye.